This question is looking at one of the sagittal section of the brain showing one arrow mark, asking us to identify the arrow mark structure. As we understand, this is a sagittal section, so this is the anterior side and that will be the posterior side. We are looking at one C-shaped structure, and that C-shaped structure, which we can demarcate by putting some colors also, is corpus callosum. Now, if we are telling this is corpus callosum and shading it with some color, say we are using the green color here, it is a C-shaped structure. During development, it develops in such way that it will be around the thalamus and making a C-shape appearance. Now, as we have marked it here, this corpus callosum, what is it? It is basically collection of axons and commissure fibers connecting the right brain with the left brain. For example, frontal lobe with the frontal lobe on right left side, occipital lobe and occipital lobe on the right left side, like that. Different lobes of the brain can be connected, commissure fibers. So if we know that it is corpus callosum or commissure fibers, fine, but what about the fornix then? Fornix is also C-shaped structure. It is also having some commissure fibers connecting the right and left hippocampus. But remember that commissure fibers is one of the component of fornix. It also has the projection fibers projecting from higher brain center, lower brain center. It has commissure fibers and it also has association fibers. Association fibers means the fibers, the axons are not going to cross the midline. They'll keep connecting the component of brain on the same side. There will be association fiber. So fornix will have all the three fibers basically. But where is fornix? Let us show the fornix also. It is also C-shaped structure. Part of it is evident here. I am shading it in this black color now. That is the fornix. What about the septum pellucidum then? Septum pellucidum is actually the structure which you can see now here, this area, the pink color which I am showing now. So that is going to be the septum pellucidum. But what exactly is this septum pellucidum? We understand that each cerebrum will have lateral ventricles filled with CSF, and these lateral ventricles, they are separated from each other by septum pellucidum. So since we have removed one half of the brain and we are looking at the other half of brain, and inside the cerebrum will have what is called as the lateral ventricles. The left and right lateral ventricles will be separated from each other by a curtain like structure, and that is the septum pellucidum. So septum pellucidum should be here. Fornix is this black color which we are showing, and corpus callosum is the green color which we already have marked. Now, what about lateral ventricle? Lateral ventricle, as I mentioned, it is a space basically within the cerebrum basically, and separated by this septum pellucidum. You will find septum pellucidum is attached to corpus callosum superiorly and fornix inferiorly. But anyway, as we have got our answer, the answer should remain choice number B, the corpus callosum. The commissure fibers which are connecting the, say, occipital lobe on the right and left side, frontal lobe on the right and left side, or parietal lobe on the right and left side, different axons will be there and connecting right and left half of the brain. So answer should remain choice number B, corpus callosum. This patient is having some aphasia, as we can make out. Here we see the male patient brought to the hospital after some severe head injury. The patient can speak fluently. There is no problem with the speech with normal intonation, but then the speech is nonsensical. So you are getting some idea that what kind of aphasia this could be. When the patient was asked to raise his hand, he is failing to follow the command, means unable to understand what the command is, and that comprehension of spoken language is compromised. We understand this is a case of Wernicke's sensory speech aphasia, and Brodmann number is 22. Let us look at one diagram and then find our answer in the given options. In this diagram, we are looking from the side view. It is basically the left cerebral hemisphere, which will be dominant hemisphere in 95% of the population, and that is where the language areas will be on the left side. So What are they? There will be superior temporal gyrus, which we can see here on the posterior part. Area number 22, which is called Wernicke's sensory speech area. It is for comprehension of language. So, as we are mentioning that this is the Wernicke's area, which is area number 22, superior temporal gyrus, more posterior. That is the one which is important for comprehension or understanding of language, and the patient has got that area compromised, area number 22. Normally, this area number 22 will be communicating with area number 44. 22 into 2 is 44. You can remember like that. So, how the axons go from 22 to 44 is arcuate fascicle will be connecting 22 with 44, or this 44 45, which is now inferior frontal gyrus. So, it is understood that this is Broca's motor speech area. This is going to be Broca's motor speech area, and it is area number 44 45. It is inferior frontal gyrus. All of these are questions they keep asking very frequently. And Broca's area is basically for planning the speech muscle movement. So, planning the movement of speech muscles, like how should I move my lip, tongue, or larynx, pharynx to produce the speech. If that planning is not done properly, then there will be Broca's motor aphasia, and there will be compromised fluency of language. Patient cannot be fluent in language. They don't make sentences. They make very few words. Broken, Broca and broken speech. So fluency gets compromised in Broca's aphasia. What about Wernicke's aphasia? Wernicke's aphasia, if the patient cannot understand the language, then he cannot actually communicate properly. He won't even understand what he's speaking in addition to what you are speaking. So won't be able to follow the command as our patient is having. And they will have this nonsense and non-stop speech, means they continuously speak, but that is, we cannot understand what they are talking about. So that will be called as Wernicke's sensory aphasia. Superior temporal gyrus, more posteriorly, area number 22 will be compromised. Broca's is frontal gyrus, in that also inferior frontal gyrus, area number 44 45. What will happen if there is a lesion in the arcuate fascicle, which is connecting the Wernicke's with Broca's? Then there will be what is called as conduction aphasia, and the typical finding in conduction aphasia is, since Wernicke's is not affected, the patient comprehension of language is good. Since Broca's is not affected, the fluency of speech is good. If fluency of speech is good and comprehension of language is good, then what is the problem? Problem is, these patients with conduction aphasia will have poor repetition of language, poor naming. So that is one of the problem which you will find, but with intact comprehension and fluency of language is okay. But anyhow, this patient, because his speech was nonsensical and he was speaking fluently, there was a problem with comprehension of language, spoken language especially. So Wernicke's aphasia, area number 22, superior temporal gyrus, more posteriorly. That should be our answer, choice number B. We are looking at the floor of the pharynx in a developing baby, and they are asking for some arrow mark structure in the given diagram. What is the name? Names are like tuberculum impar, lingual swelling, hypobranchial eminence, copula. This is about the development of tongue. So this is the first pharyngeal arch which you will find contributes to anterior 2/3 of the tongue by forming two lingual swellings. So the arrow mark is on one of the lingual swellings. There will be one tuberculum impar also, that will be in the midline, but then it will be overgrown by lingual swellings, and this anterior 2/3 of tongue will be then supplied by the mandibular nerve branch of trigeminal, carrying general sensation, and it will be having chorda tympani nerve branch of facial for taste sensation. This is about anterior 2/3 of tongue. The second arch disappears from the tongue, doesn't contribute much except for that chorda tympani nerve, which is branch of facial nerve, belong to second arch. But then since the second arch contribution to the tongue is very minimal, the nerve branch chordae tympani goes to first arch area and then carry the taste sensation. So, journal sensation by mandibular trigeminal and taste sensation by chordae tympani nerve. Mandibular trigeminal is the first arch nerve and chordae tympani nerve is second arch nerve. Now, wherever this junction is there means first arch and the third arch, because obviously second arch is disappearing, so there will be a junction of first and third arch. One sulcus terminalis will develop and one foramen caecum will also develop. Otherwise, this red color which they are showing, which is contributed by second arch, third arch, fourth arch, which is called as hypobranchial eminence or copula of His. Let us mark all those structures. They will be contributing to the posterior part of tongue. So, when we look at the developing tongue, tongue will be like this. We'll have what is called as sulcus terminalis. This is anterior two-third of tongue, and anterior two-third of tongue is developing in the first arch, hence supplied by mandibular trigeminal, but for journal sensation. If you are talking about the second arch, it was disappearing here at one foramen called foramen caecum. So, foramen caecum is the place where the second arch will disappear, but leaving behind one nerve for the anterior two-third of tongue, chordae tympani nerve. Chordae tympani nerve is a branch of facial nerve of second arch, but carrying the taste sensation from anterior two-third of tongue. Now, if the second arch was disappearing, then we will form this posterior one-third of tongue. That will be by the third arch. So, as we are looking at posterior one-third of the tongue, it will be the third arch, and the nerve is glossopharyngeal nerve. Glossopharyngeal nerve will give branches not only for journal sensation but also taste sensation. So, that is posterior one-third of tongue. What about the posterior most tongue or root of the tongue? The posterior most tongue or root of tongue will come from the arch number 4, fourth arch, and the nerve of fourth arch is branch of vagus, superior laryngeal nerve, itself giving internal laryngeal nerve. So, there is an internal laryngeal nerve, branch of superior laryngeal nerve, branch of vagus, the nerve of fourth arch, carrying both journal sensation as well as taste sensation from the posterior most tongue. Now, as you look at the posterior one-third of tongue or posterior most tongue, this all came from what is called as hypobranchial eminence or copula of His. You can mark that here. This red color, it is the hypobranchial eminence or copula of the His, and basically it was contributed by arch number 2, 3, 4, but then arch number 2 disappears, so it is basically 3 and 4 contributing. This yellow color is the place where you will have second arch but disappearing, so leaving behind what is called foramen caecum. This blue color is the first arch, and in the first arch also we have told these are lingual swellings on both sides. There will be one tuberculum impar, but that tuberculum impar will be overgrown by the lingual swellings. Tuberculum impar will be in the midline and only single. That is why in this question we should keep our answer as lingual swelling. One of the lingual swelling is here, the other lingual swelling is here. Tuberculum impar, they are overgrowing. This is all first arch area. If we were talking about the hypobranchial eminence, this is hypobranchial eminence or copula of His. This copula of His is the other name of hypobranchial eminence only, and contributed by arch number 2, 3, 4, but later the 2 is not contributing much to the tongue, and it is arch number 3, 4 contributing to posterior one-third of tongue and also posterior most tongue. But since the arrow mark is on lingual swelling, we should keep our answer as choice number B. Cavernous sinus thrombosis patient and presenting with pain involving the forehead and the orbit, but also it is mentioned that upper lip area is involved. Lower lip area is spared. So, if lower lip area is spared, mandibular nerve is not involved, and anyway it is a case of cavernous sinus thrombosis, mandibular nerve is not involved there. So, which of the following nerve is not involved? We will immediately say answer is mandibular nerve, but let us look at some detail now. Looking from the front view, you are taken a coronal section and looking inside cavernous sinus, you will see that this is pituitary gland in the midline, and let us say we are looking from the front view on one of the cavernous sinus. Cavernous sinus is a dural venous sinus filled with the venous blood of the brain. The brain drain into cavernous sinus, but inside the cavernous sinus we have internal carotid artery passing. Infralateral to that, one nerve is passing, which is abducens nerve. So abducens nerve and internal carotid artery, they are lined by endothelium. They are content of cavernous sinus. Otherwise, the number 3, 4, that is oculomotor and trochlear, and 5, 1, which is ophthalmic trigeminal, or 5, 2, which is maxillary trigeminal, they are in the lateral wall of cavernous sinus, lined by endothelium on one side, but on the other side it is approximated to the meninges, the dura mater basically. It is basically the 6th nerve, which is a direct content of the cavernous sinus. Otherwise, the number 3, 4, 5, 1, 5, 2, they are in the lateral wall of cavernous sinus, and 5, 3, which is mandibular nerve, is not at all a content of cavernous sinus, so it is not involved. These patients will have problem with ophthalmic division, which is forehead, upper eyelid, the nose midline, or they'll have problem of maxillary nerve, which is the lower eyelid, upper lip, lateral nose, cheek area, that is maxillary nerve. They'll have no problem in the lower lip or skin of the mandible, this area, because mandibular nerve is not involved, and even the muscles of mastication supplied by mandibular nerve, they are not affected. Jaw jerk will be normal. So which reflex will be affected? The corneal reflex will be affected because it is cut by ophthalmic trigeminal. The sneeze effect will be the maxillary nerve, sneeze reflex will be compromised, but mandibular nerve or the jaw jerk is not compromised, it is still working. Understand the forehead or the upper eyelid or the midline nose. The forehead, the upper eyelid and the midline nose, that is the territory of the ophthalmic trigeminal, and there will be some pain in this area. When it comes to lower eyelid and upper lip and lateral nose along with the cheek, that is maxillary division. It is the upper lip and the lower eyelid and the lateral nose and the cheek area, that is maxillary division. There will be some pain there also. But if you are talking about lower lip and the skin on the mandible, the lower lip and skin on the mandible, that is the territory of mandibular nerve, and mandibular nerve is not a content of the cavernous sinus, so it will not be involved in cavernous sinus thrombosis. That is what the question is asking. That is why we will keep our answer as mandibular nerve. It is a case of cavernous sinus thrombosis. There is pain which is not present in the lower lip. So lower lip is spared. Lower lip area is supplied by mandibular nerve. So asking what is not involved, mandibular nerve is not involved. What about trochlear nerve? Of course, number 3 and 4, they are content of the cavernous sinus in the lateral wall. Now number 6 is also content of cavernous sinus, but running directly through the cavernous sinus. So abducens is there, trochlear is there. Maxillary nerve is also a content of the cavernous sinus in the lateral wall of cavernous sinus. But if you are telling which is not involved, we'll keep our answer as mandibular nerve. Also evident because lower lip is spared, it is not involved in this patient. The pain was not there. So keeping your answer as choice number B. Diagram of mandible given. Patient presenting to OPD with the numbness in the lower teeth, mandibular nerve. Lower jaw, lower lip, chin, that is all territory of mandibular nerve. The nerve that passes through the arrow mark structure, means here, mandibular foramen, and has got involved in the patient. So they are asking about the inferior alveolus here. Inferior alveolar nerve should be the answer. Branch of mandibular nerve supplying the mandible region. We have to understand that mandibular nerve will come. Say this is the mandibular nerve or V3, the third division of trigeminal, main trunk. Now as the main trunk comes, it will give anterior division, posterior division. So anterior division basically supplies the muscles of mastication, and some branches are already given by main trunk also. But anterior division is chiefly motor. So it is chiefly motor. It is the posterior division which is chiefly sensory. When you say posterior division is chiefly sensory, what branches it give? You can remember Pali, the posterior division giving Ali branches. So what are these Ali branches? You'll see that there will be one auriculotemporal nerve, and there is one lingual nerve, and there is one inferior alveolar nerve. So mandibular nerve, as you follow, the posterior division you follow. Pali is your mnemonic, posterior division giving Ali branches. In Ali branches, the A, which goes posteriorly, is auriculotemporal nerve. L is lingual nerve for the tongue, and I is inferior alveolar nerve for the lower teeth. So you'll notice now I can draw the nerve itself. The nerve which is going to enter here is going to be the inferior alveolar nerve. Now inferior alveolar nerve is entering here. What about the auriculotemporal nerve? Auriculotemporal nerve will be somewhere here near the neck of the mandible. And what about the lingual nerve? Lingual nerve will be passing here near the teeth, which I am showing here, lingual nerve. I'll show another diagram also. So these are the three branches of posterior division. Auriculotemporal nerve, the lingual nerve is here, and this is inferior alveolar nerve. So basically, inferior alveolar nerve will go into this mandibular foramen, will be passing inside the mandible, and then come out as mental nerve. Mental nerve will be supplying the skin on the chin, this area. Let me show you a diagram also for the same. Lingual nerve, which we are showing here, is the one which will be supplying the tongue, anterior two-thirds of tongue, journal sensation carried by lingual nerve. If you say mandibular nerve is the nerve of mandible and giving all these branches. Inferior alveolar nerve is the one which will enter here. It will be supplying lower teeth, also giving nerve to mylohyoid and supplying antebelly of digastric also. So antebelly of digastric, mylohyoid muscles will be supplied by a branch from this inferior alveolar nerve. And mental nerve will be the nerve which will come out from the mental foramen and supplying the chin area basically. If you look at this diagram, you will see auriculotemporal nerve branch of the posterior division mandibular is going along the neck of the mandible. Inferior alveolar nerve is also coming from posterior division, going into mental foramen, will be passing deep to the mandible and then coming out as mental nerve supplying chin and all that. It also gave mylohyoid nerve to supply two muscles basically, mylohyoid muscle and anterior belly of digastric. All of these are MCQs basically. And lingual nerve, which is coming from the posterior division of the mandibular, is related to these teeth basically here, lower teeth, and it will also supplying the anterior two-thirds of tongue, journal sensations. That is the job of the lingual nerve branch of mandibular trigeminal. They are all branches of mandibular trigeminal. This is mandible, so mandibular nerve supply here. Obviously, if they are asking about this foramen, I'll say my answer is inferior alveolar nerve, supplying whatever area they have mentioned, like lower teeth it will be supplying, lower jaw it is supplying, lower lip it is supplying, chin it is supplying by mental nerve. So that is the answer. Lingual nerve cannot be the answer because lingual nerve will be running here, supplying anterior to the tongue, journal sensation. Mandibular nerve cannot be the answer because mandibular nerve already has given this posterior division, anterior division. It is not in relation with the mandible as such, and cannot be mental foramen, mental nerve, because mental nerve will be coming from mental foramen and supplying the chin area. So only possible answer is choice number C. A question in the neck region asking about some muscle not supplied by nerve loop, which is ansa in the neck region. So ansa cervicalis, shown by the arrow mark. You will see there is a nerve loop here in the neck region, and that is called as ansa cervicalis. We'll draw a diagram also for the same purpose. This ansa cervicalis is identified by the fact that it will be embedded on the carotid sheath. Inside the carotid sheath, you have internal jugular vein shown here, and it is anterior to the contents of carotid sheath. So inside the carotid sheath, we'll have carotid artery, which is common carotid artery, further continuing as internal carotid artery, followed by internal jugular vein, and these vessels, as they are inside carotid sheath, embedded on the anterior wall is this ansa cervicalis. Ansa means loop, cervicalis means in the neck region, and it is supplying some muscles in the neck region. For example, Muscles coming from the sternum to the hyoid bone, sternohyoid muscle, or coming from the scapular region and to the hyoid, which is called omohyoid muscle. So omo means shoulder, omohyoid muscle or sternohyoid muscle. But this ansa cervicalis, which is supplying the anterior neck muscles, it is not supplying some of the muscles which you have to remember. Like there will be a geniohyoid and thyrohyoid. The geniohyoid and thyrohyoid will be supplied by C1 fiber directly, but carried by 12th nerve, hypoglossal nerve, which is itself going to supply tongue muscles, but it also carries some C1 fibers to supply geniohyoid, thyrohyoid. Let us make one diagram for the right hypoglossal nerve here. And as you are telling that this is the 12th nerve, right side, the hypoglossal nerve going to supply the tongue muscles, but along with tongue muscles, it is also carrying some C1 fibers. Now, this is the C1 fiber it is carrying, and that C1 fiber, which is carried by the 12th nerve, has two functions. As I mentioned, it will supply two muscles, the geniohyoid and thyrohyoid. These are all named according to their attachment to the various structures. Say, for example, looking from the front view, this is the mandible bone, below that is hyoid bone, below that is the thyroid cartilage, and below that is the sternum bone. So, mandible, hyoid, thyroid, and sternum. You'll find there are some muscles like from the mandible to the hyoid bone, coming from genial tubercular mandible to the hyoid, so geniohyoid. And there is one muscle coming from thyroid cartilage to the hyoid bone, so it is thyrohyoid. Now, geniohyoid and thyrohyoid, which are both attaching to hyoid bone, hence the name geniohyoid, thyrohyoid. Coming from genial tubercular mandible to hyoid, geniohyoid muscle, and thyrohyoid coming from thyroid cartilage to hyoid. These two, they are supplied by C1 fibers carried by 12th nerve. So 12th nerve carrying C1 fibers and supplying these two muscles, that you remember. Now, what about this fiber which we have shown down there? This is the fiber which will be contributing to ansa cervicalis. Ansa cervicalis is a loop of nerve in the neck region, supplying some muscles like it will have a superior root, it has inferior root. Inferior root actually come from the C2 and C3 root value. So C1 contributes to the superior root of ansa cervicalis. C2 and C3 spinal cord contribute to inferior root of ansa cervicalis. Inferior root will be supplying inferior belly of omohyoid, which you can see coming here. This is inferior belly of omohyoid. Whereas superior belly of omohyoid will be supplied by the superior root. So as we are mentioning, inferior root supply inferior belly of omohyoid, superior root will supply superior belly of omohyoid. But where is omohyoid coming from? See, this is the scapula bone, let us say right scapula. From there, one muscle comes and it attaches like this. Scapula shoulder region is omo, so it is called inferior belly of omohyoid, and that will be superior belly of omohyoid. Now, these muscles like inferior belly, superior belly of omohyoid, they are supplied by ansa cervicalis. As you see, this is inferior belly of omohyoid and that is superior belly of omohyoid, supplied by ansa cervicalis. Ansa cervicalis, which is shown here, it also supplies these muscles, other muscles, like which one? You'll notice that there is one muscle coming from sternum to the thyroid, so it is called sternothyroid muscle. Coming from sternum to hyoid, so it is called sternohyoid muscle. So these muscles may be sternothyroid or sternohyoid or omohyoid. They are all supplied by ansa cervicalis. Now you know 5 muscles here. One is sternothyroid, one is sternohyoid. See, whatever they are connecting, that is the name, sternum to hyoid, sternum to thyroid. And one is coming from shoulder, so omohyoid. All these 3 muscles were supplied by ansa cervicalis. But ansa cervicalis do not supply geniohyoid or thyrohyoid because they were already supplied by C1 fibers carried by 12th nerve. So what is the answer? You understand the answer. Question is asking what is not innervated by the nerve loop, which is ansa cervicalis here, geniohyoid and thyrohyoid. So that is why the answer is thyrohyoid. The other could be genohyoid, because genohyoid, thyrohyoid, they are supplied by C1 fibers, which was hitchhiking, or carried by the 12th nerve. The 12th nerve, which itself is supposed to supply tongue muscles, but it also carries the C1 fibers to supply two muscles, thyroid, genohyoid. Hence, they are not supplied by ansa cervicalis. Otherwise, ansa cervicalis is definitely supplying omohyoid, maybe inferior belly or superior belly. It is also supplying sternohyoid, sternothyroid, whatever anterior neck muscles. But the not innervated by the nerve loop ansa cervicalis is thyrohyoid. Choice number D should remain the answer here. Esophageal constrictions. While performing the upper GI endoscopy, a constriction is noted 40 cm from incisor teeth. If you calculate from upper incisor, you will find that, say you are putting a nasogastric tube or orogastric tube, Ryle's tube. Calculated from upper incisor, you will find there is this pharynx and esophagus beginning, and 15 cm from upper incisor. There is a cricopharyngeal sphincter. Then there is a compression of esophagus being compressed by arch of aorta, 23 to 25 cm from upper incision. If it was still down, left principal bronchus will be compressing esophagus. We'll see a diagram. There will be around 28 cm from upper incision, and then the esophagus passing the diaphragm, and that is 40 cm from upper incision. Since it is mentioned 40 cm from upper incision, it must be the diaphragmatic hiatus you are talking about. You notice that we are calculating it from upper incision, distance from upper incision. All of these are very frequently asked questions, so you should be careful about remembering the facts. When the pharynx is becoming continuous with the esophagus, pharyngoesophageal junction, that is where there is a cricopharynx sphincter, C6 vertebra 15 cm. This is the first narrowing of esophagus. So cricopharyngeal sphincter, C6 vertebra 15 cm from upper incision, first narrowing of esophagus at the beginning of esophagus, the narrowest lumen of esophagus. Number 2, when this arch of aorta is compressing esophagus posteriorly, T4 vertebra level. Remember, it is T4 vertebra level and the marking is 23 to 25 cm. You should be careful. It is 23 in anatomy books, 25 cm in surgery books. So you can remember 23 to 25 cm, T4 aortic arch compressing esophagus posteriorly. Second narrowing. Third narrowing is because of this left principal bronchus, and that is now at a lower level. So left principal bronchus, T6 vertebra level. Vertebra level are important, they are being asked, and 28 cm from upper incisor, distance from upper incisor. What about the last narrowing? When it is passing through diaphragm, the right crus of diaphragm, esophagus is passing, T10 vertebra 40 cm from upper incisor. So you will see that this narrowing is esophageal hiatus in the diaphragm, T10 vertebra 40 cm from upper incisor. That is what they were asking in the question, and that is what we'll answer. Upper GI endoscopy constriction noted 40 cm from upper incisor is diaphragmatic hiatus for the passage of esophagus. Choice number D should be the answer. What about cricopharyngeus? It was just the beginning of esophagus, the narrowest lumen, 15 cm from upper incisor. What about left principal bronchus? Left principal bronchus was actually 28 cm from upper incision. What about the arch of aorta? Arch of aorta 23 to 25 cm from upper incision, but it is asking 40 cm. Hence, the answer should remain esophageal opening, diaphragmatic hiatus, or choice number D. Question on triangles of the neck. We understand that say there will be a mandible bone here, there will be hyoid bone here, then there will be thyroid cartilage here, and there will be sternum bone here, clavicle bone here. From the sternum and clavicle will come sternocleidomastoid to the mastoid process, temporal bone. There will be one anterior triangle of neck and there will be posterior triangle of neck. All that we have to discuss. Say this is the mandible bone, below that is the hyoid bone, below that you can say this is the sternum bone. With the sternum there will be this clavicle bone on either side. From here one muscle is coming, sternocleidomastoid, so it will go to the mastoid process. The sternocleidomastoid can be shown on the other side, sternocleidomastoid, like that. Because of that, you will see there will be triangles created, and there will be one anterior triangle, there will be one posterior triangle, anterior and posterior triangle. We'll have a diagram and look at more details, but it is in the anterior triangle you are looking now, because this is the sternocleidomastoid muscle. This muscle, as you are seeing, is sternocleidomastoid muscle. On this side, it is the sternocleidomastoid muscle. You'll notice from the mandible comes anterior belly of digastric, on right and left side. And between the two anterior belly of digastric is the arrow mark. This is under the mentum of the mandible, under the chin, submental triangle. Answer is submental triangle, no doubt, but where is the digastric triangle? Let us look at one diagram to discuss more details. You're looking from the front view: mandible bone, hyoid bone, sternum bone, clavicle bone on either side. I'll show again. Mandible bone is here. This is mandible bone. Hyoid bone is here. This is the hyoid bone. This is the sternum bone. And then these are the clavicle bones. Coming from the sternum and the clavicle bone, is sternocleidomastoid muscle. Sternocleidomastoid muscle. So this is sternocleidomastoid muscle. This sternocleidomastoid muscle divides the neck into two triangles. One is anterior triangle, one is posterior triangle. So this will be the anterior triangle and that will be the posterior triangle. You'll see that there is anterior belly of digastric and posterior belly of digastric. This is anterior belly of digastric, posterior belly of digastric. This is the digastric triangle, or what is called as submandibular triangle under the mandible. But bounded by the two anterior belly of digastric, apex is the mentum of the mandible, hyoid bone is the base. This is what we call submental triangle. So submental triangle bounded by anterior belly of digastric, right, left, and there is hyoid bone at the base. Apex is the mandible bone. This is what they are asking about, submental triangle. If you are talking about this posterior triangle now, posterior triangle, you'll have sternocleidomastoid, you have trapezius, and you have clavicle bone. These are the boundaries. Once again, sternocleidomastoid, trapezius, and clavicle. So this is the clavicle, that is trapezius muscle posteriorly, and that is sternocleidomastoid anteriorly. This posterior triangle itself will be divided into two parts. As you know, there is inferior belly of omohyoid, superior belly of omohyoid. What you are seeing here is inferior belly of omohyoid. That will be superior belly of omohyoid. This inferior belly of omohyoid, if you can see, there is a muscle shown here, inferior belly of omohyoid, will divide the posterior triangle into two parts. There is an occipital triangle and there is a subclavicular triangle. So occipital triangle, subclavicular triangle. Posterior triangle will be divided into two parts by muscle passing here, inferior belly of omohyoid. Occipital triangle and subclavicular triangle, because it is under the clavicle, subclavicular triangle. Whereas the anterior triangle is now having one anterior muscular triangle, because a lot of strap muscles will be there, anterior muscular triangle, as you can see here, where you'll have thyroid gland and all that. There'll be a carotid triangle. So what are the boundaries of carotid triangle in the anterior triangle? Carotid artery is running here in the carotid sheath. It'll be basically carotid triangle, as you are talking about, bounded by sternocleidomastoid muscle and posterior belly of digastric, and this is the superior belly of omohyoid. So these are the boundaries of carotid triangle. If you look at the carotid triangle, what are the boundaries? Sternocleidomastoid and superior belly of omohyoid and posterior belly of digastric. And in the carotid triangle, you have common carotid artery bifurcating into internal, external carotid artery. So this is carotid triangle where you have common carotid artery bifurcation inside the carotid triangle. So giving you some basic idea, but This is what they were marking, and it is called as submental triangle, and that is what we have shown. So this is anterior belly of digastric on left side, anterior belly of digastric on the right side. This is the hyoid bone you are looking at. If you look at this, this is the submandibular gland in the submandibular triangle or digastric triangle, bounded by anterior belly and posterior belly of digastric. So that will be submandibular or digastric triangle. But this is anterior belly, that is the mandible bone, this is hyoid bone. So this is the submental triangle. If you talk about muscular triangle, it will be somewhere here, where you have strap muscles like sternothyroid, sternohyoid muscles, strap muscles supplied by ansa cervicalis. Submandibular we already have told, it is the other name of digastric triangle, and it will be bounded by anterior belly of digastric and posterior belly of digastric. Anterior belly of digastric, posterior belly of digastric. So this is the digastric triangle. Mandible will be the base, that is digastric triangle. Digastric is the other name of submandibular, but since they are talking about this arrow mark with hyoid bone at the base, mandible at the apex, you are looking at submental triangle then. Choice number B is the answer. Front view of the heart, talking about arrow marked blood vessel. You notice that this is the pulmonary trunk coming from the right ventricle. This is right ventricle sending pulmonary trunk. You'll notice that left ventricle will be sending the ascending aorta, which will become arch of aorta. So this is basically ascending aorta becoming arch of aorta, and there will be superior vena cava entering into right atrium. So this is right atrium and there will be superior vena cava. But it is the ascending aorta which will be giving right coronary artery in the right coronary sulcus. It will be giving left coronary artery in the left coronary sulcus. Left coronary artery giving one branch downward, which is the anterior interventricular artery, the arrow mark. The other branch is the circumflex artery, continuation of left coronary artery. If you look at the anterior interventricular artery, which is also called LAD, left anterior descending artery, supplying chiefly the left ventricle, but also giving some branches to right ventricle. And this anterior interventricular artery or LAD is also giving some diagonal arteries. These are diagonal arteries. Diagonal arteries are also given by, this is also diagonal artery. There are multiple diagonal arteries. So the other diagonal artery can be given by circumflex artery, which is continuation of left coronary artery. Let us look at the details in the next diagram. You see, it is the aorta. First is ascending aorta, then it becomes the arch of aorta. It is the one which will give right coronary and left coronary artery. As it is giving right coronary artery is running in the right coronary sulcus, giving some branches. One of the branches is right marginal artery or acute marginal artery. They keep supplying right ventricle. Now, ascending aorta only will give left coronary artery, which you cannot see here because hidden by pulmonary trunk coming from right ventricle. If you remove pulmonary trunk, then you can see the course of left coronary artery coming from ascending aorta. Left coronary artery itself will give two branches, one going down, so it is called as anterior interventricular artery or left anterior descending artery, the one which was arrow marked in our question. The other one is circumflex artery or continuation of left coronary artery. Now, this anterior interventricular artery supplying the apex of the heart, it is giving some branches to right ventricle also, but mostly the branches are to the left ventricle. Like one of the branch given here is diagonal artery. Diagonal arteries are multiple in number, and you see another diagonal artery now. It is coming from left coronary artery. So left coronary artery giving diagonal artery. Left coronary artery continues itself as circumflex artery. So these are some of the details which you could make out, but as is evident, it is asking for the arrow marked structure. Arrow marked structure is the LAD or left anterior descending artery or anterior interventricular artery, giving some branches to right ventricle, but chiefly it has to supply left ventricle, like giving here diagonal artery. Why not? Your answer is left coronary. Left coronary cannot be seen, as I mentioned. It will come from ascending aorta, but will be hidden by pulmonary trunk. Then it will give two branches. So what about left circumflex? Left circumflex artery is continuation of left coronary artery. Here it is giving some diagonal artery also. Then why not diagonal artery? Diagonal arteries are number one here and number two here. These are diagonal arteries. Diagonal artery, diagonal artery. This diagonal artery coming from the anterior artery, and that diagonal artery coming from the circumflex artery. But that is not where the arrow mark is. Arrow mark is on the anterior interventricular artery, which is also called left anterior descending artery. Hence, we should keep our answer as choice number A. One fracture in the upper limb. History of trauma near the right shoulder. X-ray is showing a fracture. Fractured surgical neck of humerus. Clinical presentation, difficulty to abduct the arm because deltoid is the chief muscle of abduction. Especially 15 degree to 90 degree, it is more powerfully working. So that 15 degree beyond, there is a problem, and loss of sensation over the upper lateral aspect of the arm, which is called as regimental batch anesthesia, C5 dermatome, compromise. We are talking about axillary nerve here. Axillary nerve is supplying deltoid, so the problem, and it is also supplying skin. So when there is a fracture surgical neck of humerus, there is a axillary nerve damage. Axillary nerve supply two muscles, deltoid and teres minor. Deltoid is powerful shoulder abductor. Teres minor is for lateral rotation at the shoulder joint. So there will be difficulty abduction and lateral rotation. Plus, police people, army people, they keep one regimental batch here. Deep to that, skin on the lower half of the deltoid, C5 dermatome, there will be sensory loss, regimental batch anesthesia, because that is all supplied by cutaneous branch of axillary nerve. That's what the examiner is showing. Surgical neck fracture, damage of axillary nerve. You should know that axillary nerve is in relation to the surgical neck of the humerus, so it can be damaged if there is a fracture surgical neck of humerus. If there is a fracture mid-shaft humerus, then the nerve damage is radial nerve in the radial groove, and there will be a wrist drop, loss of wrist dorsiflexion with other clinical features. Radial nerve comes in front of lateral epicondyle and gives two branches. There is a median nerve which is passing in the midline content of cubital fossa along with radial nerve, and this median nerve may be compromised if there was a supracondylar fracture. So median nerve is not shown here, but median nerve will be in the midline, hence the name is median nerve, and it can be damaged, especially its branch, anterior interosseous nerve is damaged when there is supracondylar fracture. Ulnar nerve is not a content of cubital fossa because it is behind the cubital fossa. Ulnar nerve passes behind the middle epicondyle, and if there is a fracture middle epicondyle, ulnar nerve can be damaged. Sometime the patient may have tardy ulnar nerve palsy. Tardy ulnar nerve palsy is late, tardy means late manifestation of ulnar nerve injury because there is a fracture of middle epicondyle, but that is not the point here. Arrow mark was here, problem was with axillary nerve, and we should know axillary nerve supply two muscles, basically deltoid and teres minor. Deltoid is a powerful abductor and teres minor is a lateral rotator at shoulder joint. Axillary nerve also, if it is damaged, cause regimental batch anesthesia, C5 dermatome, skin on the lower half of the deltoid muscle. There will be some regimental batch anesthesia. Hence, in this question, as it is asking about this fracture, surgical neck fracture, damage is axillary nerve. That is why trauma to the right shoulder, X-ray showing a fracture. Clinical presentation, difficulty to abduct the arm, especially beyond 15 degree, because though deltoid is working at all 0 degree to 180 degree movement, but more powerful 15 to 90 degree. Plus loss of sensation over upper lateral aspect, that is regimental batch anesthesia. Area supplied by axillary nerve not working, so anesthesia. Why not radial nerve? Radial nerve, if it is fracture mid-shaft humerus, which is not here, this is surgical neck fracture. Why not suprascapular? See, suprascapular nerve, if it is damaged, first of all, it is not related to humerus bone. Second, then there will be problem with supraspinatus, infraspinatus muscle. Problem of abduction 0 to 15 degree of abduction will be the problem if supraspinatus is gone. This is beyond 15 degree. Infraspinatus is a lateral rotator that is not to be focused upon, but since beyond 15 degree, it cannot be suprascapular nerve. Suprascapular is 0 to 15 degree of abduction at the shoulder. What about musculocutaneous? Musculocutaneous is not at all related to this area of the humerus. And if it is damaged, then there will be problem of biceps muscle, like there will be difficulty of elbow flexion, or maybe it's a powerful supinator at the radial nerve joint. So supination at the radial nerve joint, or some sensory loss will be there in the lateral cutaneous nerve of forearm. It is giving lateral cutaneous nerve of forearm, not this area, regimental batch anesthesia. So that is not the answer. The only answer for surgical neck fracture is axillary nerve injury. Choice number A should remain the answer. Hand muscles, they are showing, asking us to identify and mention the primary action also at the metacarpophalangeal joint. It is the dorsal view of the hand, and these are dorsal interosseous muscle which are bipinnate, taking origin between the metacarpal bones. So this is again a bipinnate muscle. There are total 4 dorsal interossei. So one here, and this is the last one. Now, as we are mentioning, these are dorsal interossei. What is going to be their function? We remember pad and dab, palmar interossei for adding the finger. Middle finger is the axis. If you add the finger toward the middle finger, it is palmar interossei. And middle finger is the axis. If you take the fingers away, then dorsal interossei for abduction, pad and dab. So when you say pad and dab, dorsal interossei for abduction, hence you got your answer. Palmar for adding the finger towards the midline. Let me show some more details. As I am mentioning, these are seen from the dorsal side. They are dorsal interossei, they are bipinnate. The palmar interossei, they will be unipinnate. So palmar interossei unipinnate, plus we should remember P0 and D2 for the middle finger. Middle finger has no palmar interossei and it has 2 dorsal interossei. Let us talk about it more in the next diagram. You see, first of all, if it is unipinnate muscle, then they are palmar interossei. Interossei means between bones. Between bones means between metacarpal bones. So between metacarpal you have interossei, and palmar interossei are unipinnate. If you compare it with the dorsal interossei, they are bipinnate. You see, coming from adjacent side of metacarpals, 1, 2, 3 and 4. 4 palmar, 4 dorsal interossei. Also notice that middle finger is the axis. Middle finger is the axis. So if you bring the fingers close to the axis, you are adding the finger to the axis. It is palmar for adduction. But middle finger is the axis. Middle finger is the axis. If you take the fingers away, away means abduction. So dorsal for abduction. You'll notice that middle finger, there is P0, no palmar interossei. And for the middle finger, there is D2, 2 dorsal interossei. Why? As you will notice, we are telling P0 means on the middle finger, you have no attachment of any palmar interossei. Palmar interossei pulls this thumb to the midline, pulls this finger to the midline, so palmar for adduction. Why there is no attachment of palmar interossei here? As you see, this palmar interossei is pulling this finger to the midline, this palmar interossei pulling this finger to the midline, but why don't you have any attachment of palmar interossei on? Because middle finger is the axis, it is always in adduction, and because it is always in adduction, it does not require any palmar interossei, hence P0, no palmar interossei. On the other hand, dorsal interossei, they pull the fingers away from the midline. So middle finger, whether it goes towards the thumb or towards the little finger, it is always abducting. It is always abducting. So it will require one abductor for here, one abductor for that direction. That is why you see dorsal interossei, one attaches here, pull the middle finger to this side. Dorsal interossei, one attaching to there, pull the middle finger to that side. it is always doing abduction. The middle finger is always doing abduction. It never does adduction. It is always in adduction. So hence it will have attachment of two dorsal interosseae. Hence I am telling D2. So middle finger has D2, two dorsal interosseae for abduction, dab, dorsal for abduction, and that is P0. Palm interosseae is 0 because it is always in adduction. Along with this adduction and abduction, remember the 8 interosseae, 4 palmar, 4 dorsal, 8 interosseae, they help lumbricals. And what is the function of lumbrical? Lumbrical has two functions: flex the MCP, extend the IP. So MCP flexion and IP extension. That is done by lumbricals, but the interosseae also help lumbricals for this movement. So what is the answer then? See, the question is asking identify the muscle. Because they are bipinnate, we will say dorsal interosseae. Then what is the action at the metacarpophalangeal joint? Of course, palmar for adding the finger, dorsal for abducting the finger. So our answer will be abduction. But my point is, these 8 interosseae muscles, they help the lumbricals also, which do two functions: MCP flexion and IP extension. So this MCP flexion and IP extension, this job is done by lumbricals assisted by the interosseae. How? How do they do interphalangeal extension? Because they insert on dorsal distal expansion. There is a dorsal distal expansion for interphalangeal extension, and interosseae can do that. What is the first action of dorsal interosseae? It is, of course, abduction. Second action, MCP flexion. Third action, interphalangeal extension, because it is inserted on dorsal distal expansion. So remember the sequence. But anyway, since these are bipinnate muscle, they are dorsal interosseae. Their job is dab. We'll keep our answer as choice number B. A fracture shown in the radius region. Presenting with fracture, arrow mark region. Arrow mark region is here. This is the radial head, neck. So fracture in the proximal radius, most probably it is fracture of the neck of the radius, and that is where the deep branch of radial nerve, that is posterior interosseous nerve, supplying the posterior forearm, working for the MCP extension specifically, though it is also helping in wrist extension, interphalangeal extension. But because if pin is injured, posterior interosseous nerve is injured, patient presents with finger drop at MCP joint, means cannot do MCP extension. That is how it presents like. Now, if you're telling it is a fracture in the proximal or neck region of the radius, and your answer is posterior interosseous nerve, fine. Why not you take your answer as anterior interosseous nerve? See, anterior interosseous nerve, first of all, say this is the lower end of the humerus, right humerus. This is the lateral epicondyle, that is the medial epicondyle. Medial epicondyle is slightly larger. The ulnar nerve passes behind medial epicondyle. This is ulnar nerve. Radial nerve passes in front of the lateral epicondyle, give two branches. One is superficial, one is deep, and that deep branch is called as posterior interosseous nerve. So radial nerve giving two branches, one is superficial cutaneous branch, other is deep branch posterior interosseous nerve, and that deep branch can be damaged here. The ulnar nerve will be damaged if there is a fracture medial epicondyle. If ulnar nerve is passing like that, and if there is a fracture of medial epicondyle, then ulnar nerve will be damaged. Radial nerve comes here in front of lateral epicondyle and gives two branches. One is the deep branch, the other is cutaneous branch. It is a deep branch which can be compromised, as we are showing here. Median nerve run in the midline, give anterior interosseous nerve, and anterior interosseous nerve is, if you are asking, can be damaged if there is a supracondylar fracture. If there is a supracondylar fracture, the nerve involved is partial injury of median nerve, especially its branch called anterior interosseous nerve. So Anterior interosseous nerve, branch of median nerve, can be compromised if there is a supracondylar fracture. Why not ulnar nerve? Ulnar nerve, I mentioned, it will be compromised if there is a fracture medial epicondyle. Fracture medial epicondyle, then ulnar nerve can be damaged. Why not radial nerve? Radial nerve usually will not be damaged here. It will be damaged in fracture mid-shaft humerus. So if there is a fracture mid-shaft humerus in the middle shaft of the humerus, then radial nerve can be damaged, giving you a wrist drop. Since it is a fracture related to radius, that is the maybe neck of the radius, and it is very much related to this posterior interosseous nerve. That is why we are keeping our answer as posterior interosseous nerve. And remember, if it is posterior interosseous nerve damage, there will be a finger drop at metacarpophalangeal joint or knuckle joint. Now you may ask, why not a wrist drop? There is no wrist drop because wrist can still be extended by ECRL, extensor carpus radial longus muscle, already supplied by main trunk of radial nerve. So no wrist drop. Then why interphalangeal extension still working? Interphalangeal extensions can still work with the help of lumbrical and interossei. Lumbrical and interossei supplied by ulnar nerve, median nerve can do interphalangeal extension. So IP extension is still possible despite the fact that posterior interosseous nerve is damaged, and most of the extensors which are working for wrist and MCP IP will be compromised. But if there is a case of posterior interosseous nerve injury, you will find specifically there is a finger drop at MCP with no wrist drop and no loss of IP extension. Plus there is no sensory loss. Why there is no sensory loss? Because this is a pure motor nerve. Posterior interosseous nerve is a pure motor nerve and there will be no sensory loss in such a patient. Anyway, fracture at the arrow mark region is the fracture of the radial neck, and most commonly damaged nerve will be posterior interosseous nerve. Choice number A should remain the answer. Caudal section in the abdomen region, looking at the posterior abdominal wall. Relations of the kidney. There are some muscles. The most medial muscle which you will see behind the kidney is going to be psoas major muscle. Psoas major, which is coming here attaching to lesser trochanter along with iliacus for hip flexion. So there will be a psoas major, but on the psoas major there will be a small muscle, psoas minor. So as I zoom here, you will notice that we are shading the area of psoas minor. So I am making it bluish color, psoas minor. The tendon is also evident. It is lying on psoas major. So marker D, if you look at marker D, it is psoas minor. Then where is major? So that is the marking for psoas major, the black color. You mean to say marker C. Then what is lateral to that? Marker B. Lateral to that marker B, let us use the green color. Quadratus lumborum, quadrangular muscle in the lumbar region, abdomen region. And what is marker A? Marker A, which is still more lateral, muscle of anterior abdominal wall, transversus abdominis muscle. As you will see, external oblique, internal oblique, and the marker here is on transversus abdominis muscle. So this is transversus abdominis muscle. They are all related to kidney posteriorly. If you look at the posterior relation of kidney, you will notice, say this is the right kidney front view, left kidney front view, right kidney, left kidney. Medially you will find that they are the kidneys posteriorly. The muscles are posterior to kidney, will be psoas major. In the middle you will see that is dotted line, quadratus lumborum. So that will be quadratus lumborum, and if you go still more lateral, again some shaded area, that will be transversus abdominis muscle, transversus abdominis muscle. So what is the relation medial to lateral? There are three muscles behind the kidney, behind each kidney there are three muscles. Most medial muscle will be psoas major, and lateral to that quadratus lumborum, and lateral to that, which is the lateral most behind the kidney, transversus abdominis, Same thing you can see. What is the most medial muscle? That is psoas major. What will be lateral to that? The green color quadratus lumborum. What will be lateral to that? The transversus abdominis. That is why in this question our answer is choice number D. Why choice number D? Because marker A is transversus abdominis, you can see here, and marker B is quadratus lumborum, you can see here, and marker C is psoas major, which is here. Marker D is psoas minor, which is this marker, that is D, psoas minor. Hence the answer should be choice number D. A kabaddi player twisting injury to the knee when the foot is fixed to the ground. Terrible triad, 3 ligament injury. Usually happening in American football players, but can happen in kabaddi players also. So kabaddi player twisting injury to the knee while the foot was fixed. This is the mechanism of injury of terrible triad, 3 ligaments injured. Now, if it is a case of terrible triad and 3 ligaments are injured, what are the 3 ligaments? ACL tear, and then medial collateral ligament and medial meniscus also. Let us locate these ligaments now. You will see that upper bone is the femur bone. This is the condyle of femur. Lower bone is tibia. This is condyle of tibia, and this is the tibia. It's a synovial joint, so capsule will connect the bones. Capsule will connect the bone. This is C for capsule. Between the bones, you'll find there is one meniscus on the lateral side, one meniscus on the medial side. This is looking at the right knee joint from the front view, right knee joint from the front view. So there'll be a lateral meniscus, medial meniscus made of a fibrocartilage working like shock absorber, which I can show now not only in my diagram but here also. This is lateral meniscus and medial meniscus. So lateral meniscus like a shock absorber between femur and tibia in knee joint, and medial meniscus also. Now you'll find these menisci are intracapsular. Intracapsular are some of the cruciate ligaments also. They are called cruciate ligaments because they cross each other, ACL, PCL. So there's a ACL and there's a PCL. Let us draw ACL. ACL is called A because it attaches anteriorly on tibia. PCL is called P because it attaches posteriorly on tibia. Now looking at ACL, you'll notice ACL attaches anteriorly on tibia and run backward, upward, lateral to attach to lateral condyle of femur. So you can remember a bull. What is that? A bull. What is that? Anterocruciate ligament runs backward, upward, and lateral. So attaching anteriorly on tibia is ACL, running backward, upward, lateral. As it runs backward, upward, lateral, attaches to lateral condyle of femur. Now PCL is called P as it attaches posteriorly on the tibia and then attaches to medial condyle of. So the one which you see the tear here, let me zoom here, let me put some color coding also. Attaching anteriorly on tibia is ACL. This is the tear in ACL, and ACL was running backward, upward, lateral, attaching to lateral condyle of the femur. PCL is shown there behind it, and PCL is attaching posteriorly on tibia, anteriorly on the medial condyle of femur. This is medial collateral ligament or tibial collateral ligament. It is extracapsular, which we can show in our diagram. These are the 3 things which are damaged in terrible triad. In terrible triad, there is a ACL tear, there is medial meniscal tear, and there is tibial collateral ligament tear. Let us show the 3 in our diagram as well. So one is medial meniscus, one is ACL, and the other one, which is extracapsular, let me show with black color, the tibial collateral ligament or medial collateral ligament. So this is the tibial collateral ligament or medial collateral ligament. This is the medial meniscus, and that is the ACL. So these are the 3 ligaments which are gone: ACL tear, medial meniscus, and tibial collateral ligament. The terrible triad is ACL tear, medial meniscus, and tibial collateral ligament. They are compromised, and because the tear, as they are asking, it must be ACL as the answer. Now, if you say ACL is your answer, which test will be positive? Anterior drawing test is positive. Normally, you cannot pull the tibia anterior, prevented by ACL. But if there is ACL tear, anterior drawing test become positive. A modification of that is Latchman test. Latchman test become positive because again it is checking for ACL tear only. Only thing is Latchman is less painful because it is not done at 90-degree knee flexion. It is done less than 30-degree knee flexion, so less painful, but is highly specific, highly sensitive for ACL tear. Latchman test again comes as a question. So we'll keep our answer as ACL. Why not PCL? Because PCL appears intact. Anyway, the history is not giving the detail of PCL. PCL is dashboard injuries, and the PCL are more stronger. ACL injuries are more common, they are less strong, they are weaker ligaments. Why not medial collateral? Because they are not showing medial collateral ligament tear. Why not lateral collateral? Lateral collateral will be on the lateral side. The tear is evident in ACL, hence the answer remains choice number B, ACL. The anterior test is positive and Latchman test is also positive. Choice number B should remain the answer. Varicosities, dilated, elongated, tortuous veins, varicose veins, can happen in cases of long-standing professions. There is a pooling of blood, and because there is a pooling of blood, the valves become incompetent. As the valves become incompetent, mostly in the perforators, the blood will come from deeper veins into superficial veins, and in the superficial veins there will be pooling of blood, and because of that pooling they become dilated, elongated, tortuous or varicose veins. Like this is great saphenous vein we are talking about. Dorsal venous arch on the medial side forms great saphenous vein, runs like this. This is a location of great saphenous vein or long saphenous vein, identified by the fact that it will be running anterior to medial malleus, runs anteromedial on the leg, goes slightly posterior to the knee joint, again runs in the medial thigh. So medial thigh and medial leg and anterior to medial malleus. This is the vein which is shown here, dilated, elongated, tortuous. Now, if you are telling that it is a 62-year-old traffic police officer, long-standing job, pooling of blood, damage of the valves, incompetent valves in the perforators, and then deeper veins sending blood back to social veins. So prolonged standing, obviously it's a traffic officer, so they need to stand long for quite, they should be using their soleus often, the peripheral heart, to push the blood towards the heart from the calf region and right lower limb. As you see, it is asking primary incompetent vein. So primary incompetent vein, sometimes you may be confused that maybe the answer is perforator vein, but no. Perforator veins, if you take your answer, then it won't be this evident great saphenous vein. So the best answer should be great saphenous vein. Cannot be short saphenous vein because it will be on the lateral side, not on the medial side, lateral leg basically. And what about posterior tibial vein? Posterior tibial vein is a deeper vein. You cannot see that so superficial. This vein which you are seeing is great saphenous vein, evident because it is subcutaneous, it is superficial. Posterior tibial vein is deeper vein and won't be evident at all in this appearance. So varicosities, location, appearance all go in favor of great saphenous vein. Choice number A should be the answer.